Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, Stephanie Desmond talks to Michael Kotlikoff, the provost at Cornell University. They discuss how Cornell, with its 28,000 students, faculty, and staff back on campus this fall, has seen COVID-19 rates below 0.1%, fewer than 100 cases since the semester began. Let's listen.
Michael Kotlikoff, thank you so much for joining me.
Great to be here.
So you're the provost of Cornell University, and you have invited all your students back to campus. Tell me a little bit about how you've been able to do that where others have not.
Well, that's a complicated answer. We've implemented a number of safety programs, including first gateway testing or entrance testing, everybody that was to come back. And then a very rigorous surveillance testing program that tests students twice a week. We did the other things that you would predict. We've set up a contact tracing program in cooperation with our county government. We've modified our spaces. We put in place behavioral guidelines. We've got travel guidelines, lots and lots of components to this, lots of people working on it. We started pretty early trying to do that. Probably the biggest thing that we did was build our own testing laboratory in a facility that we had that does surveillance testing for animals, interestingly, and is used to doing high-scale surveillance testing. And that allowed us to control all of the information, to have the information, to get our test results very quickly. And we did this epidemiologic modeling very early on that told us how often we needed to test to be able to operate safely, and also made some predictions about what would happen if we went online that were concerning, that those students that would come back and not be monitored would likely produce more infection within our community.
So you determined based on these models that not having classes on campus, not inviting people into the dorms could actually be worse because those who moved sort of back into town wouldn't be constantly tested and constantly surveyed.
Exactly. That the predictions there would be that absent surveillance, and we wouldn't have a way to really compel surveillance for people coming back and not having an open campus, that would produce lots and lots of transmission. We used the fact that we were opening and our campus facilities are open, our labs are open, our libraries, and the fact that we had in-person instruction to as the mechanism to enforce being part of the testing program. So you can't access any of those activities unless you're up to date on your testing.
So maybe I try to swipe my badge to the library and you wouldn't let me in because I haven't been tested?
Exactly.
So how many cases have you found since classes began? And I understand that you have, between students, faculty, and staff, you have roughly 28,000 people on campus. And I understand you've only had 100 positive tests. Is that right?
Correct. We had, most of the positives were early on as students came back. We had actually predicted that our prevalence would be close to 2%. We did that based on the data that we saw around us. West Point, for example, had their students come back, 1,000 cadets come back, all asymptomatic, and about 2% of those kids were positive. We had predicted we'd get about 2%. It turned out we got about 0.2% of our student population coming back that was positive, which was great. But you can do the math, and if you have 19,000 students, that's still a lot of positives. And so that initial entry into a fairly low prevalence community caused us to identify individuals that were positive. The thing that we've been able to do is identify them and isolate them and then really prevent transmission. And of course, the way to stop a epidemic or a pandemic is to prevent transmission.
Absolutely. So I realize that the cornerstone of all of this is a lot of testing, and that is not cheap. And I know that colleges and universities are in some dire straits these days. Is there a concern about the expense of this, of trying to test everybody so often?
Well, there is, and we are spending a fair amount of money doing this. We determined early on that, as I said earlier, it would be safer to do it this way. We had no really 100% safe options. If we didn't test, we knew we were going to have a lot of disease. We just knew we wouldn't know about it until people started going into the hospital. We were, by building the laboratory ourselves, able to drive down the cost of testing really significantly. And that was another important thing, both by pooling, so doing this efficiently, and by doing it ourselves. We've done a number of things that have been able to drive down the cost of individual tests. But I would say one other thing, and that is we have about 98, 99% of enrollment. And we were concerned, and I think others have seen, that an all online curriculum results in some melt of enrollment, some deferment for students taking gap year, deferring their admissions, et cetera. And we have not experienced that. And of course, the financial cost of that would have been significant as well.
Mm-hmm, mm-hmm. So as we've seen sort of with this White House super spreader event, testing isn't enough. So what else have you done that others could potentially emulate that you think has helped keep your rates so low?
Well, the first thing I want to do is give credit to the students who are taking this seriously. We mounted a campaign to really communicate that. We were very clear early on as we had students come back and some clusters. We were very clear about the consequences of unsafe behavior. So students are number one, but I would also point to two things that we're doing, innovations that have been undertaken by the testing people. This has been led by Gary Koretsky, who's an immunologist, Lauren Warnick, who's the dean of the vet school who oversees the testing lab, and Diego Deal, who is running the testing lab. They meet every day. We actually have two meetings. They have a testing group meeting every day and look at the results of the tests and really understand where the positives are. So they've instituted two innovations. One we call adaptive testing. So if we get a positive, of course, the county, our health department, is responsible for identifying the contacts according to their definitions, their interviews and definitions. And we work very closely with them. It's been a great collaboration. But they have certain definitions. We understand the full network of those kids. So we'll take a student and do what we call adaptive testing, where we'll test the entire network immediately. We get our results back within that day, the day of testing. And we've isolated a number of individuals who have not been identified as contacts, but were positive and would have gone out and spread. And of course, the major thing about this population, and the thing we knew going in, was up to 80% of individuals in this age group have no symptoms at all, are completely asymptomatic, don't know they're infected, but are very good at spreading the virus. So one innovation is what we call adaptive testing. And that's sort of looking forward. Where could this individual have spread? Another is looking backward. So we have this response team that says, where was this individual likely to have acquired his or her virus? So we go back, interview, think about where that person was. Often it's a travel event now because we're such a low prevalence at this point. But we've also identified individuals that are suspect that are behind, that are the cause of this person's infection, gone back to that individual and then that individual's network. And so the whole focus really is to try and stop transmission.
Mm-hmm. I've spoken to officials at North Carolina where the kids came back to campus and were sent home very quickly because they spread the disease so rapidly. I've spoken to the president of Michigan State who decided not to open in person at all after seeing those behaviors. The sense has been that students cannot necessarily be trusted to change their behavior. But I think you're arguing otherwise.
I am. I do think that's a facile. It's an easy tag for students, and certainly we didn't expect 100% compliance. But I think what we've seen is the vast majority of students are responsible. They get it. They understand the risk, and we're seeing a lot of pride here in being able to stay open, being able to do something and accomplish something that is understandably difficult.
Mm-hmm. So I'm from Buffalo, New York, and so I know that winter is coming and it's not going to be pleasant weather-wise in Ithaca, New York. It's easy right now to have students outside, socially distanced. Once the weather gets cold, how are you going to be able to sort of keep this momentum going?
Yeah, it's a great question, and we are concerned. So I think there are a couple issues that we're looking at now and concerned about. One is just this sense of overconfidence. We're down at 0.01%. That means, on the good side, that we have a very low prevalence in our community. And as I said, most of our infections we're seeing now are from kids leaving the area and then coming back into the area having contracted COVID-19 outside. But the ability for students to continue throughout the semester to comply with behavioral regulations is tough, and there is fatigue here, and we're worried about that, combined with, as you say, the fact that students are going to be indoors more, and we know that's a more dangerous site of spread. So we are continually monitoring this. We're talking about we're messaging that quite a bit. We will end our in-person instruction at Thanksgiving. Students will go home. Every student is required to get a influenza vaccine, so they will be vaccinated. They will go home. We're talking now about an exit process, and then also the process for continuing to test throughout the rest of the semester for those students who stay local, not in our dorms, although some will provide housing for, but most students in dorms will go home. There will be students that come back into College Town, our local area and our local community, and then in the intercession after the semester and before we start again in the spring. So all of that we'll continue to test. We'll do some exit testing. We're talking about that protocol right now. And we'll continue to monitor. And we've got through this data meeting, and we have been meeting up until last week. The president and I met every day and talked with leaders about the cases and our quarantine availability, our isolation space availability. We've now made that backed off to twice a week, but we're watching this very closely, and we can adjust by more testing, by changing, by going in and extensively testing in areas where we're seeing outbreaks, and those sorts of responses.
Michael Kotlikoff, thank you so much for joining me.
Thank you. It's been a pleasure.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.